economy, the surge, and what's next for Humboldt County. Our goal is to provide you, the residents of Humboldt County, with the most up-to-date information regarding the state and local response to COVID-19. Our hope for tonight is that you will be informed and empowered to continue helping protect our county from this virus. Over the next 90 minutes, Humboldt County Health Officer Dr. Teresa Frankovich, Deputy Health Officer Dr. Josh Ennis, Sheriff William Honsal, and Lost Coast Editor Hank Sims will participate in a discussion about the risks and rewards of reopening the economy. The group will also discuss what must happen before we begin the reopening process and how that process might look moving forward. I will be serving as a timekeeper to move the conversation forward and make sure we get to all of the topics on our agenda. I'd like to note that tonight we do recognize our participants are not wearing facial coverings. This is because we'd like you to be able to hear what they're saying clearly. However, we are practicing social distancing tonight. As of 12:01 a.m. tomorrow, facial coverings will be mandatory for Humboldt County, as this is the first key step to reopening our economy. Our participants will be following that order when it goes into effect. If you have questions following tonight's broadcast, please contact our COVID information line at 707-441-5000 or email covidinfo@co.humboldt.ca.us. We'll give you that contact information again at the end of this broadcast. I'm now going to turn it over to Hank Sims to begin tonight's discussion. Hank.
Thank you, Samantha. I wanted to start by just stepping back and acknowledging how the sort of big picture of what we're dealing with and how strange it's been for everyone. Yeah, this new disease was discovered at the end of last year, halfway around the world, and now these days, more American citizens are dying of it than heart disease or cancer on a day-by-day basis, and those are usually our two top killers of Americans. And we still know so little about this disease. We don't know how many people have contracted it exactly. We don't know how many people have died from it. We don't know the number of people who carry it and don't know that they carry it. And we've had to improvise as a society. We've had to improvise our response as we learn what it is and how it works. Early into this, a month ago, I heard somebody say that, well, if everybody in the world were able to stand stock still for 14 days, then no one would ever have any problems ever again. This would be gone. This disease would be gone from the face of the earth. That's maybe a bit of an exaggeration, but it's sort of the one pole of a continuum of responses that that are conceivable. The other pole, I guess, would be everybody in the world contracting the virus tomorrow. What we've tried to do, I think, as a society, is to find a path that between those two poles that causes the least harm for the majority of people. California and Humboldt County in particular, I think, have done very well. We've reduced the number, we've slowed the spread of the virus much more quickly than other places have. But that comes with a cost as well. That means that more of us are still, the illness and death that other places have experienced are likely still ahead of us here in Humboldt County. We're not immune to the virus. So tonight we want to look, I think, what we want to do is look at the next phase of the fight, look forward to the next phase of the fight against the virus, which will come at some point when the county and when the state are ready to start slowly and strategically reopening parts of society. In the months ahead, life is going to be difficult. It's going to be different than we're used to it being before we had learned of this virus, I believe. We're going to have to struggle to keep it at bay and at the same time open up so that people can earn a living, that we can take care of our elders, that we can hopefully send our children to school. But what can we open and when? How can we monitor the spread of the virus? Will we have sufficient resources and systems in place to monitor that spread here in Humboldt County? And will we have to shut down again if things get out of hand? So let's talk about where we are and where we're going. And I think we wanted to start first talking about a little bit of the economic cost to the county of this first phase, the shelter-in-place order. Yeah?
Yeah, thank you, Hank.
Sure.
As a part of the EOC, we have economic development leader, Scott Adair, is our economic development director, who's compiling numbers and addressing the day-to-day issues related to businesses throughout the county. And so it's a very, very important job right now in our EOC is to track the economic issues that this local emergency has created. And so this is obviously very, very serious. A lot of people have lost their jobs. A lot of businesses have shut down, and the economic impact here has been very, very severe, and we recognize that. It is a part of public health and also public safety to always value life over property. And so that is our number one concern always. And so we are going in that direction right now. Now we recognize that there's things that we can do to build things back up. And so that's an important step. But I want to thank this community for all the steps that they've done to sacrifice the things that they did for the lives of people here in California. So it is very, very important that did happen. But some of the numbers I want to run that I think are very, very important for the community to realize is that we've lost about 2,100 jobs here locally. There are unemployment claims of close to 8,500. We have 15 permanent building closures at this time. And we have 608 businesses that are self-reporting impacts. Overall, we have a revenue loss of $28 million here in the county thus far. And that is a huge impact, obviously, countywide. But we want people to know that there are avenues for people to get assistance. And so 180 businesses have called our economic business lines, and they have asked for assistance, and we're actively trying to get them assistance. The Headwaters Fund is working with local agencies such as Redwood Region Economic Development Commission and Arcata Economic Development Corporation for a local emergency loan fund. That's actually going in front of the Board of Supervisors tomorrow. And so that is, I'm sorry, not tomorrow, but on next Tuesday, excuse me. And so it is very, very important to try and get more stimulus into our local businesses that way. And so getting these loans out there, again, is very, very important. And we do want to recognize that most of the unemployment claims have jobs that have been furloughed. And so these are the jobs that we think most of them will open up as soon as business starts opening up here in the county. And so we're thankful for that, and we recognize that as part of one of the key factors in starting the economy and getting people back to work. There is support and assistance still ongoing. We had our COVID business information line, which is 268-2527, and all these will be on our website at humboldtgov.org. You can get all this information there, and also looking for counseling guidance and for small business development, call 445-9720 or online at northcoastsbdc.org. So I do want to mention one more thing, is that I don't want to underscore the fact that that the stress that this whole coronavirus has created on our community, and mental health is a key component of that. We understand that that people are struggling, they've lost their jobs, they see businesses failing, domestic violence, child abuse, people are getting bills they can't pay, rent that they can't pay, mortgages, all those things. That we do have a mental health line here in the county, and it's toll-free, 888-849-5728. And they can call that crisis line and get the help and some direction that they need, and it's not a bad thing to reach out for help in this time. So I encourage people to do that.
One thing I was going to mention, Hank, too, is that, sometimes the question comes up about, do we look at just public health? Public health, a lot of people think of us as just dealing with infectious disease, and we certainly have that lens, and COVID has really brought that home. But the other piece of public health is really that broader look at social determinants of health. So looking at how things like the economy and education and mental health and all of those things, poverty, people's environment within their home, how all of those things impact health overall. We know those have long-lasting impacts for people. And so when we look at this, we look at that ongoing balance between dealing with the infection in front of us and dealing with all of the community impact and long-term health impacts as well of the measures we've put in place.
Yeah, it's acknowledging, right, that there is a cost to what we've done so far.
Absolutely.
And in health and in dollar terms and
Right, kids' education, all kinds of things. Fortunately, the schools were able to pivot quickly and set up, distance learning and maintain food for kids and all of those things that have helped to support that. But, we still want kids in school, so.
Well, let's talk a little bit about, there are two orders. There are two, like, sort of shelter-in-place orders that we deal with here in Humboldt County in the state of California. I believe that Humboldt County, I think, one day before the governor issued a sort of dramatic shelter-in-place order for the entire state. So maybe as we think about the next phase of what, at some point, I don't think we know when. Maybe I'm wrong about that. Maybe you guys know the secret date of when things are going to start reopening.
That'd be great to know.
But there are some frameworks in place for the governor's order at the state level. Yeah, we're looking at certain matrices to meet. If we meet this, then we can open that. And here in Humboldt County, I think, I believe the saying is that we can be more restrictive than the state, but we cannot be less restrictive than the state's shelter-in-place order. So maybe we should talk a little bit about, as we think about the day, someday down the road when things start to open up again, what that looks like, how the governor's order relates to our own order here in Humboldt County, the differences between them, and how we might relax.
Sure.
Yeah, you want me? I'll start off. I think what we need to recognize here in Humboldt County is that from the very beginning, our public health order was in line with the state, which means we weren't more restrictive than the state in sense. So there was we allowed a lot more things than other counties have done. People have shut down beaches, have made parks and going out and anything recreation beyond your home is forbidden in some counties. And so we've been able to do things here in the county based on the fact that we live in a 4,000 square mile county. We have a lot of social distancing already in place in our county just based upon our rural lifestyle. And so there's been a lot of I guess, easing of it, just because we never had it in the first place. And so I think people don't realize how good we have had it here as opposed to other counties. But we can't make any movement beyond our shelter in place until the state pivots and they start opening things up. That's why the state gave us a roadmap and said, these are the 6 things that we need to go through to make sure that when the shelter in place is opened up, that you have these 6 things essentially in step with the state. And so we are preparing for that. And Dr. Frankovich and the EOC, we're working on several things now to make sure that we can hit those points when the governor's office says we have that green light.
Yeah. And, no, I wish I had an absolute timeline, Hank, on this, but honestly, I'd be very surprised if we don't hear something within the next 1 to 2 weeks from the governor on plans to ease the governor's order. And the whole point of the framework really, as the sheriff said, is for us to be ready in that moment to move forward without delay on the things that we can open up. So this planning and preparedness piece is huge. So one thing I was going to do is, Dr. Josh Ennis has not really been in any of the media things to date, so I wanted to introduce him. He's serving as our deputy health officer during this. He's an emergency room physician, emergency department physician by training, and has a lot of experience in this county in the healthcare system here, including EMS, the hospital-based care, and such. So he's been a huge addition to this, and I just wanted to introduce him to the group. So we truly appreciate. I truly appreciate him every day too. So
great. So as we think about there's been a lot of pressure locally here, I think from people in maybe non-essential businesses or businesses that were deemed non-essential for the purposes of this shelter-in-place order. How have you been able to make it clear to people where this pressure is coming from? That in some ways, like, our hands are tied. Yeah, our hands are tied at the state level. By the governor's office.
I think so. I mean, I think people understand that, and we've tried to put that message out there for sure. We've looked at the orders, we've compared the orders, we've looked at, for those opportunities in there, and we really are amazingly closely aligned to the governor's order, as the sheriff said. So I think really that being the case, we're really focused on these preparedness pieces, again, so that we're ready to launch and make the move when we get some easing of those restrictions. So we've been paying a lot of attention to what's going on, because we know that, you know, we, as incredibly successful as we've been in the sheltering in place, and we have been amazingly successful, there are things we need to consider going forward, and we've sort of alluded to that. We will see an increase in cases when we start to move out of this. That is undeniable. And so we have not eliminated COVID. In spite of the zeros we've been racking up on our cases recently, we haven't eliminated it. We've just made it much harder for it to spread by keeping groups of people from mixing. And so we know that, you know, as a community, we know we can't stay exactly where we are. That's not tenable for the long term, and that there are costs to remaining as we are, societal costs. But we also know that moving too fast and not being able to really help identify those indicators that would suggest we're getting in trouble, that could actually have a huge cost as well. And so we're really looking at this as, how do we walk that path, as you mentioned, forward? And what I'd like to do is, we've been talking a lot about modeling, and you know, across the state and locally, and Dr. Ennis was going to talk a little bit about models, both from the state, which we received this past week, and also about what we've done with that information and our own to try and create a little bit of modeling as well.
That's
So.
great, yeah.
Yeah, and I'd like to just maybe piggyback on what you were saying about use of this time. You know, I think that the economic impact and the social costs have been incredibly great, and so I don't want to downplay that at all. But using this time to plan and prepare as a county and have a county-wide approach has been really invaluable. There are scenarios that we could have never have imagined that possibly could play out, and so being able to organize around that at the speed of lightning over the past couple weeks has been really valuable. And so, you know, I don't want to get too far ahead to the modeling.
No,
but,
go for it.
So maybe I can just talk a little bit about some general principles of the modeling before I go through the slides. You know, when we look at modeling, I think it's worth saying that modeling is just that. It's a model. It is in no way predictive of what's actually going to happen. And there are a lot of assumptions made about how the virus is transmitted that we don't actually know, and we won't know until this is all settled, maybe 2-3 years from now. So it's kind of like, it's guesswork to some degree, but it's an educated guess, and it's based on data and what we do know.
And I'd suggest it gets a little more of an educated guess as we go. Right?
Yes, and the further along we get, the better the data gets, and the more the model can hone in on probably the actual course of things. You know, and one other thing, you know, and we've already spoken to this a little bit, is that, you know, these models are based on what's happened in more urban areas, and so there is a difference between rural and urban. We don't really know, there's no data to suggest if that difference is really quantifiable in a large way or not, but it's all to say that there is some uncertainty around these models. That being said, it's the best that we got, and it's
Yep.
worth looking at to help us guide our plan and, as we respond. So I'll come up here to the actual models, and so this first curve was released by the folks at the CDPH, California Department of Public Health. And this is basically a curve that they generated with the assumption that there are no interventions left in place whatsoever. This model was generated using the Hopkins software, which is open source. You can find it online. This is based on data through March 24th, so it is a month old at this point. The reason I bring it up is because it will be helpful to try and put into context what we're talking about and what kind of time frames there are. I don't want to explain too much on this graph itself, but to maybe just highlight that we're really going to be focusing on just this first part. So this is zoomed in on that first part of the curve there. And this dotted white line, which you can see going up here, is the first part of that curve. And so using this model, they ran 1,000 simulations playing with some of the different transmission values that they know what the ranges are, and modeled what happened in each of those 1,000 simulations. And so this is what they came up with. They ran it 1,000 times, and they took that middle value and they plotted it out on the curve here. And this is assuming that we have non-pharmaceutical interventions, or NPIs, or what we're calling mitigation, or effectively it's the shelter-in-place orders that are in place right now. And this middle value on this blue line here is what the state is suggesting we focus on. Just below this, you can see these red dots here, and this is the actual epidemiologic curve across the state of California. And one thing you'll notice is it's tracking along just below the median value, okay? And so you might say, well, did we get it wrong at the state, the state modelers? I think that's not quite the correct conclusion, because what I haven't pointed out here is that there's a cone of uncertainty here based on those 1,000 simulations going up and down. And you can see that as we go along in time, this gets bigger and bigger. I think what's important to point out here, though, is that as we go further and further along this timeline, you can see this upper range gets bigger and bigger. And I think one of the big takeaways here is that spread of the disease can quickly spiral out of control. And you could think of it as a 100-car freight train, and it's speeding along down a railway. You know, you have to pull a brake, and it takes a long time for it to slow down. So there was county-specific modeling data from CDPH. As I already pointed out, it's about a month old at this point, and so it does not take into account the actual numbers that we've had over the past month. And so I think it's more useful to talk about some of the modeling we've done at the local level that takes into account the more recent numbers over the past month. And so that's what I'm going to talk about here. So what if we left everything in place, the shelter in order in place for the next 9 months? What would that look like? I'm not suggesting that that's going to happen. This is just for the sake of defining one end of the spectrum, and as Hank called it, a continuum of a response, right? So if we left things in place for the next 9 months, and we ran the simulation, and I should mention that this is with the University of Pennsylvania, their open source model as well, which was chosen for a number of reasons. Someone much smarter than me, our epidemiologist, could go on and on about why. But we've been using this model for a variety of reasons. So if we leave everything in place, this is what we'll see. We see this plays out over a very long time, 9 months here, okay? And then along our y-axis here is the number of patients. And so for each of these curves, this is one point in time in a hospital. Okay, so when we're talking about these numbers, we're talking about one point in time. This is how many people are sitting in a bed. So when we see this number of 145, I'm talking about 145 COVID-19 patients sitting in a hospital bed. Similarly, 64 ICU patients sitting in a bed in a hospital, 38 of them on a ventilator, and up until this point, 28 cumulative deaths. And so this death number does not take into account what happens on the back end here. People continue to die on the back end of the curve as well.
Dr. Ennis, I'm so sorry to interrupt, but I think this might, there might be some kind of clarification that's helpful. Dr. Frankovich, I was personally myself confused about this slide when I first saw it, and I think Dr. Frankovich cleared it up for me, but maybe you could clear it up for our viewers as well. It's intuitively hard to make sense of the fact that for a week or, for a long time, our case count, our positive tests, which is the best measure available to us, I suppose, of the spread of the virus in Humboldt County, has been flat or pretty flat for a long time. So it's hard to sort of intuitively understand why, when our transmission rate seems, by the available data, to be low, to be going down, why there would be a big balloon, a big curve that goes up in December.
Yeah, so I think the curve you're referring to is our actual epi curve locally, and it's looked something like this. Am I correct?
Yeah.
So to put this in perspective,
Although the bulk of those people are presumably recovered, or what we're choosing to call recovered, and so no longer transmitting.
yeah, so if we could make this a completely closed system and we were able to seal off the county completely and there was no one coming in and everyone stood in place for 14 days, as you jokingly suggested, it's possible that we'd be able to really develop a pure containment strategy. And we were talking before we got started about New Zealand. They're adopting essentially a pure containment strategy. We don't live in a vacuum. People are coming in and out. People are moving around still. People are in the home, potentially exposing family members if they've tested positive, even though they're isolating. It potentially generates more cases. We don't have the ability to test everyone we want to test. And so there's low-level circulation out in the community right now, even though we're not picking up. It's out in the community.
I mean, I'm sorry, but to really, that point, to really understand how much is out there, we have to be able to do surveillance testing. We have to be able to test everyone who's symptomatic, and we have to be able to test a lot of people who are not, and that would give us a true idea of where we are right now. Our 0 cases don't represent the number of people with COVID in the community. They represent the number of people that we've tested who have COVID, and that's really different.
The other quick thing, I'm sorry, go ahead.
And the testing is strongly biased at this time because we've had to, because of limited testing, we have to prioritize who we test, and it's going to be biased because of that. We know that pre-symptomatic and asymptomatic transmission plays some role, and we thus far have mostly been unable to test those folks.
The other very quick question I have about this slide is the number of ICU beds. You say there that this would be below capacity, but the number I think that's been out there is that there are 27 ICU beds available in Humboldt County, and that seems to be much more than that.
Yeah, so I think later on I'll talk about some of the stuff that I've been doing with the hospitals to build capacity and build surge capacity even outside the hospital walls. And I can speak to that point. I've been working with the hospitals across the county to really expand their own internal plans and try to support them taking care of the sickest people within the hospital. And this is kind of taking a step back to talk about strategy. I'll just use this opportunity to do it now. It doesn't make sense to build a whole new hospital outside of what already exists. That requires a lot of infrastructure. You need to be able to have all the gases in the wall. You need to have a large staff. You need to recreate a lot of processes. So really what makes sense is to make this ICU space critical patients be cared for in the hospital setting. And in effect, you are displacing some other person who could be potentially sitting in that bed. And I don't want to get too far ahead of myself, but that's kind of the working strategy that we've been using, is to enable hospitals to take care of sicker patients, and then we'll create a mechanism to care for maybe the less sick who might be displaced as a result.
And for comparison in there, Hank, I think what you're alluding to is when you look at, our baseline capacity compared to what the hospitals have been able to do, that number of ICU beds comes much closer to that 64 than it is at baseline.
At this point, and we're still working on this, but in general, I would say the hospitals that are capable of caring for ICU level care patients, they've generally tripled they have plans in the works for tripling their capacity. So this is kind of the far end of the continuum of our bookend here of a potential response. And now on the complete opposite end, let's say that we've put all these orders in place, and then on May 1st, we lift the orders and people go back to behaving like they were prior to COVID-19 ever being in the world, okay? What would that look like? So we can see here that the curves look generally the same in terms of shape, but I just want to point out a few things. This time scale is about the same, okay, 9 months, and I'll just point out that the other curves were way over here. So we see the curve here with fewer physical distancing orders or facial covering orders in place. We see that this curve gets shifted much sooner. Okay, that is one general conclusion. Additionally, these curves are all on the order of 6 to 7 times higher at peak. Okay, and again, I'll remind you that these numbers represent number of patients sitting in a bed in a hospital. And you know, and I don't think we put this up here necessarily to frighten people, but this is what the model says, and this is based on the best available data, and this is clearly a situation that would overwhelm our hospital capacity several-fold, potentially.
I'm wondering, I'm not sure if everyone is actually being able to watch this as opposed to listen, so I was thinking it might be useful to just talk about the numbers a little on there.
Yeah, thanks for reminding me. So, so what we see for hospital bed occupancy is just shy of 1,000. We have up here 976 patients sitting in a hospital bed.
At one time.
At one time. We have 408 patients sitting in an ICU bed at peak, 251 patients on a ventilator, and up until this point, we have 188 cumulative deaths, okay? And then that does not account for the deaths that occur on the downslope here of this curve. And clearly, this is just far beyond what we are capable of caring for in our community, and far beyond what we could even, with robust surge plan capability, be able to care for. So to put this in perspective, I thought it'd be helpful to put the two curves together on a slide. This just graphically represents, you know, how far apart the curves get pulled, how much flatter the curve is. Out on the far end here, we can see that as time goes on, the curves are separated by several months. One is 6 or 7 times higher, the other one is much lower. There is a line drawn on here for licensed bed capacity at 275, and we can see that the one bookend here of current orders being in place still puts our ability to care for these patients well below the licensed bed capacity. This is just the hospital bed occupancy, so people sitting in a hospital bed. I haven't included the ICU patients sitting in a bed or a vent or deaths, but they're all on the order of about 6 to 7 times higher. And you may ask, why do the deaths go up? Well, it's likening it to the 100-car train. You know, we have a couple breaks on that train. One is the community mitigation orders, the shelter-in-place orders. And that is a strong break. You know, we really stopped in the tracks. That's why we see the curve really flatten down. But as we talk about rolling some of those things back, you know, we're not going to have a very strong break in the setting of limited testing. And so as we talk about modifying the orders, it's really important that we have robust testing in place so we can actually know what's happening in the community, and we can test, we can trace, and we can isolate. That is a huge piece of this that really needs to be in place, along with the 5 other measures in the governor's framework before we take that step, I think.
Yeah. And I think, you alluded to the fact that we are a rural area, and one thing I've heard from people as well, we look really different than the Bay Area or New York City and that area, and so, why would we ever get to that point? And I think, it's a good point. As Dr. Ennis mentioned, the models don't really distinguish between rural and urban, so that's a limitation. However, I want to point out to people that even looking at our local model, we show this disparity where we have an exceedingly high hospitalization rate, ICU rate, death rate, and then at the other end of the spectrum where we're able to keep that very low with everything in place. Is it possible that rural areas will play out differently? Absolutely. But I think as we move forward, we have to keep in mind the idea that there are huge consequences if rural areas play out like this. And so right now, it's, again, the best information we have, and we just have to have an understanding that going forward, we're going to be navigating the place between those curves and trying to basically conserve lives, never overwhelm our healthcare system, while at the same time allowing some of that societal recovery that we're talking about.
This might be a good place to ask. I think a lot of people have noted certain tests, studies, what they call the antibody studies or the serological studies that have been done recently in Santa Clara County, in Los Angeles, in New York. Today there is a big study in New York. And I know that all that is very preliminary, but I think people are taking a lot of hope from it, suggesting that the virus has spread much more widely than previously anticipated. And I don't know if you can talk about the preliminary nature of those studies, or how much credence that the county is placing in those as of now, or how they might affect some of the modeling that you just showed us, Dr. Ennis.
Sure. There's probably a few responses to this we can chime in. One is that, and we had actually been talking about this a bit earlier, is that when you do a test at a time where there isn't a lot of circulating disease, so for instance, if we start doing flu testing in August, when we know there really isn't much flu, when you get a positive in August, especially on certain tests, you go, no, I'm not sure that's right. And so in areas where there's limited, spread, some of those positives that you get may not be correct. And so we just have to accept there may be some inherent error in those numbers. But also, the thing I would point out is that we know in some of these areas they've been having a fair bit of transmission, and even so, when you look at a community that may have evidence that perhaps 5% of the people have already been infected, based on some testing and statistics, it still suggests that there is, maybe 95% of the population who is not. And so while I think it's reassuring in some ways to find some evidence of immunity out there that may help us, we're not tending to see the kind of numbers that would suggest that we've got a large portion of the population immune, and so we're out of the woods, I guess is my thought on that. And the other piece of that is we don't know what that underlying number looks like in our rural area compared to the Bay Area and cities.
I guess the idea being, though, on another aspect of those tests, and again, I believe, I'm not the scientist, but I believe that they're very preliminary and not, I don't know how much credence to place in them.
Yeah, so both those studies, they shared some of the same investigators. They were using a test that was later banned for import by the FDA because of concerns about validity, because of, going back to the point about the flu testing, because of concerns about the ability of it to actually pick up cases that are, all cases. If you have a really low level, it really underperforms. And so I think there are a lot of concerns about how the study is conducted, as well as, the actual instruments that they used. It's going to be up to the academic community, I think, when it goes through peer review. But, my impression is that there's a lot of controversy surrounding these studies.
And there are some other numbers coming out too. So we'll look, and don't get me wrong, I think the antibody testing is hugely important, and it's going to serve us well in the long run, but at the beginning it's a bit rough. So we take all of it with a bit of a grain of salt when we look at some of these.
So maybe thinking again about what the next steps might be in reopening parts of the society, parts of the economy.
Sure.
I think what Dr. Ennis was showing us here is that we're trying to steer a middle course. We're trying to keep the goal of it is to keep below that line of with our medical capacity. But we do know, right, that we are pretty sure that more, as we open up slowly, bit by bit, that more people are going to get sick, and more people, and more people are going to die.
We call it threading the needle.
Uh-huh.
I think Dr. Ennis used that the other day. I'm like, that's kind of a good visual.
Yeah, no one knows exactly where the right target is to hit. But there are certain, I think we've alluded a couple of times to the governor's roadmap, the 6 things that we want to meet before we start, say, easing up on what we have called non-essential businesses and allowing them to reopen, or schools or public places. And there's some other, I think we've all read like a Johns Hopkins study about, or advice to governors, fact-based advice about sort of a risk matrix.
That's that one.
Yeah, approach to reopening things. Just to finish up, I guess, maybe with our discussion of the difference between the governor's order and our order, do we have, I mean, first of all, I suppose, although we have flattened our curve quite a bit and meet probably on our own a lot of the governor's guidelines for reopening, we're tied to the state, of course. In the state, we had, I believe, the most deaths in California yesterday, the highest number of deaths from COVID-19 to date. So in some sense, we're at the mercy of the state, I suppose, in some ways. Yeah.
Well, what I would say is that, in some ways this is going to be very local as we go forward. In some ways, we'll be looking at the entire state because we're all going to be involved in response. I think the governor's framework is really talking about those preparedness pieces that everybody needs to have as we move forward. I mean, every community really does need to have these pieces, and the idea is to make us ready to be able to deal with whatever comes as a result of opening, right? And so, when we look at those things, we're talking about, one of the big things is the masking. And I know it's not necessarily popular, but we see it as a precondition for being able to ease restrictions. We know that as we start to, again, mix people from different households, we start to bring people together in common spaces, there's more opportunity for transmission. The things we can do as we move forward are to, even as we open, to keep social distancing principles in place, to do the frequent hand washing, to do the hand sanitizing, the cleaning of surfaces, all those things that we've already been talking about. But the masking is another tool that we can use to kind of decrease that spread of virus as we begin to combine people. So that's one piece of our framework going forward, and getting this in place will help us be ready when that announcement comes. But then there are all those other components that you alluded to, and what I would say is we haven't been ready on all of those. And this has been a time for us, as Dr. Ennis said, to really start to looking at check boxes, even though we've been looking at and working on a lot of these things. Where are we on this continuum? Are we ready? What else do we need to be ready? And so it's given us that opportunity. So as we were talking about testing, we need to be able to navigate this course well. We need to have a really good idea of how much virus is in our community. And we've been limited by having some limits on our internal capacity to do that. We are, locally, we've been fortunate compared to some communities because we have a public health lab. And that's been able to go from, at the beginning, I think we were testing 20 people per day. We've been basically able to triple that capacity, which is huge. But public health labs in general are not meant to be the kind of labs that churn out hundreds and thousands of specimens. And so moving forward, I think the governor's task force on testing has been critically important because, one of the big issues we faced internally is supply chain. And I already see some easing of that as he's been working on this with the team. And then the other real piece of this, aside from supply chain, is how do we get more of those high throughput labs? You know, we don't have to necessarily run everything here, but we need to be able to get specimens that we collect to a lab that can run them quickly and get us results. And that's how, you know, we're able to access more things like surveillance testing of people who don't have symptoms or who have really mild symptoms that we haven't been able to test so far. Didn't really look like COVID, but we know COVID can look like a lot of things. So I think that testing piece is really important, and I think we've built a lot of capacity. The commercial labs have helped, and we've been in really good conversations with the state about what we need here in Humboldt particularly, and what the state can do to help us out with that, and I think we've made really good progress. I think we're gonna be poised over the real short haul, the next, you know, even week or two, to really be able to look at having capacity to do some of the things we want to do, both from all of our internal and external work. So that's one really big piece of this, so that we can monitor as we go forward and know if we're getting in trouble.
Yeah, oh, go ahead, Sheriff.
Can I just add to that too? There's a lot of things that are happening behind the scenes that we can't really talk about right now. But there's some things that are going to be happening in a couple weeks, just like Dr. Frankovich said. I do want to urge that one thing, as I see as a level of frustration with the governor's order, is the fact that it's not a one-size-fit-all state. So we should not be treated the same way as Los Angeles County. And so, you know, though all the framework is, you know, the roadmap is there. And if we are on that roadmap and we're meeting those requirements, then we shouldn't have to wait for another county to catch up. So if we're meeting those benchmarks, and I think the governor should allow us to then, you know, modify, or allow us to modify our shelter in place. And that should be an order that's across the state. And so I think the people that are calling Dr. Frankovich and I, you know, should call the governor's office. And so allow him to make that decision to, you know, again, allow the counties to make this decision here while keeping essential travel, you know, only, you know, to the county, and allow us to, you know, meet these benchmarks for the roadmap.
Well, I would guess, I would ask then, though, Sheriff, like, do we have the capacity to make those kind of calls on our own? Do we have, I mean, I guess Dr. Ennis has showed us that we do have some sort of local modeling capacity, but we don't, I think, not yet have the capacity to trace, you know, to do contact tracing as much as we would like, or to do as much testing as we would like.
No, that's right. But the fact is that, I mean, we have a roadmap here, and we have some things that we are doing and are going to be doing the next couple of weeks to really increase our capacity. And so, again, if we meet those benchmarks, and the governor is still hesitant, he wants to push out another 30 days, but we're there, you know, he should allow us to ease some of those restrictions that are in place by the state. So if we get there, you know, again, as a goal to put out through our community, because there's a lot of things, St. Joe's, Mad River, all the hospitals are getting together, working with our public health, and really, really embracing, you know, our alternate care sites, and working with us to you know, expand our capacity. Dr. Ennis is working tirelessly with hospitals to really increase their capacity, to prepare for that surge that potentially could be, you know, coming sometime this summer. You know, we can continue to prepare for that, but also have these things in place to start easing some of those restrictions.
I mean, I guess the other thing, I mean, we don't live in a vacuum, of course, Humboldt County. I joked with you at the beginning of all this, Billy, I don't know if you remember, I joked with you about, like, is there a plan in place to blow up all the bridges? And,
That's right. Exactly.
And you replied in more detail than I would have thought.
We don't want to discuss that here.
But you know, even the governor, you know, is realizing, or in his outreach to the other western states, you know, that we are, that even California cannot isolate itself. Humboldt County cannot isolate itself. A big part of our economy is tourism. If we, I mean, we cannot. I don't think we would want to make the call on our own to say, you know.
No, absolutely not, and that's not what I'm saying here. But he's laid out the roadmap, and so he's laid out some specifics here, and we've been working on those specifics even before he laid out the roadmap. And so if we can actually get there, I just don't want to say that, you know, and I believe that in the next week or so, just like Dr. Frankovich said, that there will be some announcement to when, but, you know, that may be by the state. But, you know, in the meantime, it's like, we just would like to have some of that light at the end of the tunnel that I think is necessary.
You say in the next week or so.
We're going to see something that comes out. I would believe the governor's got to let this community know, the state know what his plan is for opening up the state.
Yeah, I mean, I would guess that, you know, one of the things in this John Hopkins study that I've read, that I believe you've read, is that we want to see a decline in cases for over a period of 14 days. I don't believe that the state is anywhere near that.
Well, I think actually that when you look at hospitalizations and some of this, you know, it isn't necessarily, some of it is sort of a plateauing or decline. And I think the really important criteria is that we're not seeing an increase, for sure, in this, or an increase of a significant level. So I think there are many places that are actually there, and so some of those preconditions, where everyone's not going to meet probably all preconditions at the same time, and we'll still have to have some movement. But you're right, we're an interdependent state and country, and we realize things that happen, even though we don't live there, things that happen in the Bay Area can have an impact on what happens here. And so we need to be cognizant of that as we move forward. But I think, you know, the sheriff speaking to the idea that, you know, as we're prepared and ready, the hope is that we'll be given the opportunity for some local decision-making and local control on some of these issues. And then, but you're right, the underpinning of that is, do we have the tools to be ready? And so, you know, just again, we talked a little bit about testing. You mentioned, Hank, the contact investigations. Testing in those are really critical in this. And when we started with the public health response on this, you know, our normal staffing for communicable disease investigations, 3 people. We are now at about 30 that we've been bringing people on board for training. And we've even brought in investigators from the sheriff's office. We've brought in our environmental health specialists. We've brought in all kinds of people that we've been able to train and then work case investigations under the supervision of the nurses. And so, again, we're just blossoming this, but it is absolutely critical that we have vibrant, responsive teams so that it's safe, so that when we identify a case, we can test contacts quickly, we can follow up on them, isolate, quarantine, and I would submit that our success with our 52 cases has been largely because of how good a job we've been able to do at containing spread from those cases. And we'll need that as we go forward. The other pieces that the governor talks about are being able to protect our vulnerable populations. So, you know, having the capacity to make sure, for instance, our skilled nursing facilities are prepared, that they have the right PPE equipment, that they have an ability to cohort patients, that they can address a case that emerges, those things, that we can do surveillance to make sure people are healthy. The other pieces of that can be making sure that seniors, who are going to still be asking for quite some time to be at home and not be mixing, or people with medical conditions, that they have what they need to be able to do that at home safely. Other components, the ability, as we talked about, for hospitals and healthcare systems to respond. Dr. Ennis has sort of addressed that a bit, and one of the underpinnings of that are alternative care sites that we've been working on, and I don't know if you want to mention anything about that,
Yeah,
Josh?
sure. So I've been working extensively with the hospitals throughout the county to have a cohesive countywide approach. And, you know, I've already kind of mentioned this, but we're trying to build the capability to care for the sickest of the sick within the hospitals. Some folks are going to be pushed out of beds who are much lower acuity, and we're working on the plans within hospitals to create more space and get all the way to their licensed bed capacity, and in some cases maybe even beyond. And then beyond that, it's kind of a tiered approach. We're in discussion with the hospitals about supporting an alternate care site. The idea, I think the first tier response would be to act as a pop-off valve, so to speak, for some of the very low acuity patients who have COVID-19, who maybe just need a day or two of oxygen, who can walk around, mostly take care of their own needs, so very low acuity, and maybe they just need their housing situation sorted out a little bit. Maybe they need to protect an elderly person who's at home still. And so, you know, being able to give those folks a place to receive ongoing medical care that is very low needs. And so we have a couple places in mind, and we're working to firm up some of the details surrounding those couple of sites. You know, as we look to actually stand up these facilities when they're needed, we need a way to monitor the bed situation. And so I've been really involved in developing some markers across the county that track the number of beds that are in use, track the number of ICU beds, the number of vents that are used, and it keeps a running tally over time, and we can see what the trajectory is, so that we know when we can anticipate when we need to mobilize some of these things. This is all great to increase the ability to handle a surge, but if we're looking just at the hospital, we're going to be too late to the game, and it's gonna be out of control. And so this goes back to the testing capability is huge, because it's going to be the leading edge, not what's happening in the hospital. We need to be able to know what's going on in the community.
Hospital's a later indicator, for sure.
It's a much too late indicator.
Right.
And you know, we've had this order in place for how long now? A month, and you mentioned that
19th of
deaths
March.
are at the highest daily death count. So, you know, it takes time to slow it down, and if you're looking just at the hospitals, that's probably too late.
Yeah, I gotta say, like, the thought of like standing up additional facilities to handle capacity, it's nice that people are thinking along those lines. I'm very glad that you guys are there thinking along those. It's a little frightening, yeah?
Yeah.
And I think that one of the things, you know, we had thought I think I told you all, or I told you maybe through your colleague there, that an early essay that sort of informed my thinking about this was called "The Hammer and the Dance." Yeah, and I think I've seen it. I think it's a lot of people have read this in the popular world. You guys are probably all reading.
No, we read it.
Oh yeah, okay. And it just occurs to me that like the idea that we, for a time, you know, we have to, like, as we're doing now, like putting down the hammer as best we can to stop, to slow the spread of disease down to as low as we possibly can, and to reduce the number of people who are carrying it, and hopefully who have recovered, ideally. And then we have to go into this phase where we manage the disease as best we can, until we get to some place where enough of us are immune, either through having caught it and recovered, or through a vaccine that we can.
Or that we have therapeutics in place.
That's what I was going to ask you about. So, like,
It's another piece of the framework.
Yeah. So during this period, the hammer that we're undergoing now, the idea is that we use this time, and it's a sacrifice, as we've said. It's a big sacrifice for our society. The idea is that we'd use this time to get certain things in place, like the testing capacity, the tracing capacity, and ideally, I think, to develop some sort of, therapy, a vaccine, which is, I think, very far out, everyone says, or some additional therapies. And I wonder, like, are we in a place now, or is there anything on the horizon where we might be able to treat the disease in better than we do now?
Sure. Well, and as you alluded to, the vaccine, we're in a little different position than we were with H1N1 flu, which some of us remember coming on the scene. And at that time, we just had to basically tweak an existing flu vaccine to be able to have a vaccine that was effective. So it took us, I think, a few months to kind of get that going. But as you recall, I think we started with it in the sort of late flu season, and by the following August, September, we had some vaccine. And so that was really helpful. With coronavirus, there's no pre-existing vaccine we can model or just tweak a little bit to make it fit. So vaccine is probably reasonably, 12 to 18 months off for us. And so the therapeutics, are there things that we can use? You can imagine that when you see these outbreaks that are causing massive hospitalization and deaths, there's a rush to try and find things that may help people who are severely ill. And so there have been lots of sort of clinical protocols to try different drugs and see what might work. And so we are definitely seeing some of that. Some things that had seemed to maybe have some promise at the outset, based on very early studies, like the anti-malarial medicines, probably aren't panning out as we had hoped. But there are other antiviral drugs, for instance, like remdesivir, that may do better. plasma from people who have recovered, the antibodies, basically harvesting the antibodies from people who've recovered and using them to treat people who are severely ill, may be promising as well. And as we have more people recovered, that's going to be more of our therapeutic option. And then there's just incredible exploration and research going on around this. So are we there yet? No. But if we latch on something that really changes outcomes, that is a game changer for sure, because especially if it's something we can use early in a course and keep people from getting really, really ill.
Well, okay, so we're building out capacity. Yeah, we're building out testing. We've got a good tracing team in place. We're planning for a surge of patients. We're looking forward to. So, we're looking forward to preparing for the worst, I guess you'd say. Yeah. So, Sheriff Honsal, you mentioned that you thought hopefully soon the governor would be. Your hands are tied a little bit by the governor right now. Our hands are tied. But I guess, looking forward, like what, here, let's talk, the John Hopkins study we had, we read, had a sort of risk assessment model, yeah? And I don't know, I was thinking maybe we needed a risk-reward model as well, what the risks of opening certain categories of places, bars or sporting, the basketball games, right, or things like that, parks, things like that. There's certain risks and certain rewards. And it sounds like you're hoping that the governor will devolve some of that authority to local jurisdictions. I mean, do you feel like you have the capacity, the county has the capacity to make these sort of calls about what businesses, what facilities might open, and what the risk of opening those facilities would be?
Well, I think there's also frameworks in place. CDC has provided guidance, CDPH, as well as we've received great advice and guidance from our public health director, and she is again in consulting with CDC, CDPH, and all of our colleagues. And so what we're doing is we're getting ready for this next phase. We know that the state will relax their restrictions sometime in the future, and then we will relax our restrictions sometime in the future. So what does that look like? What are the different tiers? What are the different phases that we're going to go through? We are not going to say, hey guys, back to normal, just like we talked about what happens when that happens. In a month and a half, we're at surge and we have 1,000 people in the hospital. Mm-hmm. So that's not going to happen. We are going to then tier this off and do those non-essential business that do contribute to quality of life, that do contribute to different aspects, but still provide social distancing, still provide a framework for people to make sure that they have trust in the business, that they're going to go in and be able to shop and to be able to purchase things that can be free of the virus, right? Mm-hmm. And deal with employees that are free of the virus. But also, we're going to be in the business of trying to essentially give advice to these businesses, saying these are the things that you should do to make sure that you have a business that is compliant with with all these social distancing and advice from our public health officer to make sure that we are doing everything possible to stay below that curve. So that's the kind of things that we are doing, we're planning, and that's one of the things that we were going to, I think, get to it towards the end, but kind of incorporating the cities and the tribes and the county supervisors to try and help us try to steer that about what is important for the community, but also what is the balance here that we have to maintain to make sure that we stay below, that point of getting people sick that is beyond our capacity in our hospitals.
I guess, what would you be most concerned about? What are we lacking the most right now?
Well, one thing I would point to is the last couple things on the framework that we hadn't hit on yet. One is that we need to have in place the ability for businesses, schools, and childcare facilities to implement social distancing measures that we'll need going forward. So even if we lift this absolute restriction on things, what is that going to look like? And so, as you mentioned, Hank, this is like a huge planning period. And so we've been in conversations with the schools, for example, what could that look like over the next few months? Are there things that we might be able to do in the school setting? When we're not talking about full classrooms, that type of thing. Can we put measures in place that will allow some form of operation? Or again, in the fall, what is school going to look like? What things can we put in place if we're operating schools to make them sort of safer in terms of transmission? So this is a really active planning period, for instance, for schools. Businesses, we want to invite to that planning as well and input about, looking at what pieces do they need to be able to implement in their workplace to keep their employees and their customers as safe as possible going forward. And I know the Sheriff's Department has been working on this in our information center on helping even now the essential businesses meet those standards for sure, as best as possible. And the sheriff might want to talk a little bit about what they've been doing along that, because I think it's an important piece of preparedness.
What we want to do is actually compliant businesses right now that are essential, we want to actually certify and provide an affidavit for them to sign to say, we have gone through the social distancing guidelines and the guidelines of the public health to maintain a proper business, and then provide them that affidavit, sign affidavit, and then provide them a compliance notice, which is essentially this, that they can hang in the window, that they are compliant with the public health officer and that they can operate as business, and people can recognize that it is a safe place and under compliance of the public health officer's order. And so we're going to begin doing this. One of the easiest ones that we can, that a lot of restaurants have already implemented a lot of those guidelines right now. And as long as they're going through these guidelines, they sign their affidavit, we will be issuing these compliance notices in the next few weeks. So starting there and then moving on from there, because
for like the takeout and
absolutely. So right now, the ones that are compliant with the public health officer's order right now, and so as one of the first things that could happen, in the coming stages, is restaurants could open to a certain extent. But what does that look like? And so those are things that we're going to work with public health to try and say, what does a restaurant operating a dine-in facility look like? And then provide that affidavit to the restaurant to saying the tables have to be a certain feet apart. These are the kind of things that have to be in place for you to be able to operate a dine-in restaurant. And so they can, operate. But some of the standard things that are going to be a part of any business here that wants to operate is having a washing station, hand sanitizing station, being able to have social distancing. So if you have any kind of line, there's 6 feet that's in between there. Some of those basic things we already see that are at grocery stores, that are banks, and things and protections in place for employees, and so all those things.
But to reach that stage, I mean, first of all, we need the governor to ease up on restrictions. Second of all, we need to acquire the kind of capacity, right, that Dr.
Yes.
Frankovich, Dr. Ennis were talking about.
Yes.
And it just seems that seems quite a ways away. Like the kind of testing that no, you don't.
I don't think so.
No.
I think we're we've been sort of hitting walls along the way, particularly with the supply chain and even things like getting swabs and the tubes to put the swab in. And I think what we're seeing now, the governor's office basically said this is a priority and we're going to make it happen. And so they've been doing all of these sort of private, public, academic partnerships to try and up capacity. And I think it's working, frankly. And so I actually feel like our testing capacity, it's not there today. But I honestly do feel like in the not too distant future here, over the next couple of weeks, that we actually have a good shot at being there. And that, because that is our big safety meter going forward. Again, all those other pieces we've built, I think we are in our internal hospital surge. I think that's good. Our ACS, or the alternate care sites, we've actually got a lot of those building blocks in place. Working with under that umbrella of the Emergency Operations Center has really helped, because we've been able to expand the infrastructure, so we have people working on this piece and this piece to move it forward, and that's just really accelerated our process. And people can imagine when you start a response like this, you are starting from scratch on developing that infrastructure to really do all the planning and implementation you need. And I think we've reached this critical piece now where we kind of have so much of that in place to forge us ahead. So I think we are actually getting closer on that front.
So you envision being able to test, as you said, like not only all symptomatic people, but asymptomatic people as well.
That's my hope, actually, and I think it may start a little bit smaller. When we do testing, for instance, for surveillance, You know, you can have very large groups of people for surveillance, or you can have small and you do some modeling based on that. And so I think, you know, I think we're getting much closer than you know, we've been able to hope for, even if we looked just 2 or 3 weeks ago. So I'm encouraged. But to your question about moving forward, you know, and what that could look like, you know, I don't know if you remember when we started this, it was, you know, no groups over 200. Then it was no groups over 50. Then it was 10. And then it was no groups outside your household. So as we unfold this, you know, I'm envisioning things like we start with, you know, groups up to 10. You know, and you'll be able to go out to dinner with friends, and then, which all of us would love to do probably at this point. And then if we would, basically as we move along, and the sheriff alluded to tiers of things, usually the recommendation is you start with some of these things that you can do, maybe restaurants open that can do all the social distancing and things we want in place, and then we wait, you know, like an incubation period's 2 weeks. You know, so maybe we wait a couple incubation periods and then we open up the faucet a little bit more. And, you know, we watch and see what happens and we open it more. And the more robust our testing and monitoring and tracing, the easier it'll be to sort of slowly open things up. And that's kind of the model we're looking at. There may be times it's entirely possible. The sixth thing on the governor's framework is how do we know when we've done too much and we need to pull back?
Right, yeah. I mean, it does strike me that it's a bit difficult to go out to dinner with friends when wearing masks. I'm not quite sure how that's going to work.
Well, you know, for instance, in a restaurant, what you might look at is you space the tables, as we said. You have wait staff wear masks. You have wait staff work with only particular tables, so you're not like having multiple people come to your table. Maybe you use a menu that's paper and can be discarded. I mean, there are cleaning surfaces in between the diners. I think there are ways we can do it, actually. But, you know, again, it comes to that planning piece for these businesses to be ready. When we get signaling from the governor that we can move forward, that'll be having them ready to go will make everything go much faster. So.
Yes, definitely.
So are you prepared to start communicating? I mean, we did want to talk a lot about the economy because that was one of the titles. It's one thing people are worried about right now a lot, and it's the title of our talk. Are you communicating with businesses now about these kind of things? I think you alluded to the fact that
This is going to be our first stage. We really need to do that, and then supply, you know, some of the businesses that are deemed essential, and give them these certifications now, and work with them now on these affidavits, and then build from there. And so making that very, very clear as far as the expectation goes, and then build from that.
Do you have yet in place an idea of which non-essential businesses, which non-essential services you might open or allowed to open? So
we have ideas that we've talked about, we've roundtabled, but we're looking at the community to inform their elected officials. And so we're going to be reaching out to the elected officials in the cities and the county, as well as tribal governments, to provide that data for us, what they believe is really essential to them, and then for us to be able to talk about that here. The decision ultimately is going to be with Dr. Frankovich, you know, and our policy committee, you know, but what we can do and slowly open that faucet like she talked about, and what would be the first stages that we could open up. There is some guidance with CDC about, you know, what can be done in opening in stages, and like you said, the Johns Hopkins study. So there's some different guidance that we can utilize, but also we want to hear from the community what's very, very important, because I think there is some give and take there that we can do in our small rural community if it's in line with the governor's order. Because the governor could be very specific and could say no dine-in restaurants, or, you know, something like that, or no clothing shopping, you know. But we recognize that clothing shopping here on the North Coast, you know, is important, and we should be able to buy shoes and clothes for our children, and so that may be one of the first things that opens. So, this is, like, as we said, this is something you're going to have to manage, and it's something you're going to have to dial back on. Are you think that? Can you get across to people, the business community, that we're going to let you open now? We might have to close you again.
Yeah.
I think it is important. I think what Dr. Frankovich talked about is this first stage. What really is important is the masking, you know, and having that facial covering there as the first stage, because if that could really be a game changer for all this to continue down the road. And some people look at this as a huge inconvenience, but it really is the first stage of trying to get things opened up. And for compliance with this, and then get compliance, and then start opening things up and maintain these kind of restrictions in place and the virus doesn't spread rapidly, and we're able, like the doctor said, to open more things, and it'll be more beneficial for the community.
Right, but you might have to close them again.
It's possible. I'm hoping, and maybe.
It's certainly possible. I mean, you can think of the local epidemic as expanding and contracting, and, we have to pull that lever potentially. And so, I mean, it's certainly possible. I think ideally, we do graded baby steps, and we have the the measures developed and in place to really guide our response. And the bed tracking metrics that I've been working on, I think with widespread testing, we'll probably be able to develop some metrics for what's happening in the community as well to guide that response. But I think we do need to prepare for that possibility. Ideally, we don't have to do that, though.
Right, and some models of, in other countries have talked about that sort of, contract, expand. And if we're able to have all the tools in place to do it really well, hopefully we don't have to do a whole lot of that pulling back. Worst case scenario, we're pulling back into shelter in place. And, we'd all like to avoid that. And so again, it's hard to go slow sometimes, and we want to get people up and going, but we want to do it in a really thoughtful way. And so I think the better we are at it, the less chance we're going to have to go back. Yeah. And so we just need to, again, navigate forward.
I guess it just strikes me that Humboldt County, like having been spared so much so far compared to urban places or even other rural places in the country, that the danger really lies ahead, and it's a difficult dance that you're doing here.
That's true.
And not only that, but I think we're a little bit older maybe than the rest of California. I'm not positive about that, but I know for a fact that we have more what they call comorbidities that don't play well with COVID than much of the rest of California.
Yeah, rural communities tend to skew a little older and skew a little into that more, as you said, comorbidities.
Uh-huh. So it's going to be. I mean, it's very difficult. Like what you're trying to steer a course, I gather, between some people will say that have said that the cure is worse than the disease. This is a common refrain that you see in some quarters, which I don't think it's quite true. But there is definitely like a downside to staying bottled up.
Absolutely.
As we started.
Again, it goes to those social determinants of health. I mean, we know there's an impact on the overall current and long-term status of people in terms of their mental health, in terms of their physical health, in terms of overall well-being. So we can't sit tight unendingly. It'd be nice if we could just, as you mentioned, just sort of all pull back and do nothing, but that's not feasible. We can't survive that way, and we won't flourish that way. So we have to move forward. We just have to do it the best way we know how, and as we've sort of said, it's somewhat uncharted territory. We can learn lessons from other countries, and we've been trying to learn those lessons as we go, but at some point we're going to nudge forward, and we're just going to have those tools in place so that we can manage appropriately as we see increases.
What indicators will you use to determine when you should pull back and tighten up society?
Right. Well, as Dr. Ennis mentioned, once we're admitting a ton of people to the hospital or ICUs, it's probably too late to make to be able to stop that in its tracks. So we need to use those early indicators. There's surveillance tools we can use. Are we seeing more people with cold or flu-like seasons, which would be unusual at this time of year? Are we seeing people buy cold and flu medicines? You can actually track some of that online. Are we seeing, but our really big thing for us is if we're doing enough testing, we're going to be able to pick up, are there X number of cases right now, even in asymptomatic people? And how many does that look like a few days from now? How many does that look like a week from now or 2 weeks? And really tightly monitoring that so we can know how much increase in COVID is in our community.
Do you envision doing randomized testing of the population?
Well, what our version of that would essentially be doing testing of asymptomatic individuals, right? So if we're testing people who have no evidence of COVID clinically, and we just plan to test them. So we can test, for instance, our healthcare workers, first responders, people who are, work in the grocery store as a cashier, people who have high exposures. We can test them for symptoms because they're going to be like the canary in the coal mine potentially in terms of having more exposure. But yes, we can also test people in the community who have no particular reason to be at higher risk. We don't have to test everyone, as I mentioned, to be able to get a pretty good idea what's out there. But all of those groups are valuable to test so that we have some underlying idea of where we are in the pandemic.
And if we can keep our prevalence or the percentage of the population that has the disease fairly low, like ideally under 10%, we actually don't need to test that many people to have a pretty good idea what's going on in the community.
Right, just statistically.
It's a lot statistically, and it's a lot more than what we have now, but that bar is not too far away. It's obtainable.
You're saying if we keep the percentage of the population that has the disease low, then it's easier to detect statistically what that percentage would be?
You don't have to test as many people if the prevalence remains low.
Okay.
So once someone's recovered, they're not part of that number. And so if you can slow it down enough, you can keep that number low, and you don't need to test too many people. If you have a lot of people with disease in the population all at once, then the number you get from a limited sample is more likely to be drastically off. And so, thinking about the strategy, it goes to speak to, testing is really going to play such a critical role as we start unrolling things.
The final thing that we maybe haven't talked about a lot is on the governor's roadmap is being able to protect the elderly and the at-risk most. What sort of systems will you have in place to detect, or to combat or detect an outbreak, like in an assisted living facility?
Sure.
Or in the jail? What will we have at that point?
That's been a really big area of importance because we're obviously hearing a lot of us about outbreaks in nursing home facilities, that type of thing, in other areas. So, we've actually taken a little advantage of the fact that there hasn't been as much demand for tests because I think there isn't as much respiratory illness yet in this shelter in place. We've done a good job at containing COVID, and the other viruses that usually circulate are taper off at this time of year, right? We don't see a lot of cold and flu as we head into spring and summer. So we've taken advantage of that to start doing some sampling within skilled nursing facilities, but increasing our testing capacity will allow us to do even more of that. And so you can envision a time in which we could, for instance, sample staff in nursing facilities, and we can do that not just once, but we can do that on an ongoing basis so that we can monitor and know when a case emerges, particularly someone who has no symptoms. So for instance, someone working in a skilled nursing facility who is working because they feel well, a staff member, but they actually have the virus. And so if we're able to identify those folks before we get spread within the facility, we can save lives in our most vulnerable people. So those kinds of things can help, as well as I think we alluded to earlier that if we're going to be asking our more vulnerable people to shelter essentially longer than other people, then we need to support them in their home environment to be able to get the things they need to do that successfully. So if we're going to do that for a longer period of time, and I envision protecting this population for a while as we emerge here.
Will it be a sort of juggling act? I mean, if God forbid something does break out within an assisted living facility, and we get hundreds of people getting sick, as has happened elsewhere in the country and in the world, will that have effects on what businesses will we have to shelter? Will other people have to shelter in place at that point, given that we won't have the hospital capacity possibly?
Yeah, well, and Dr. Ennis can chime in too, but I think part of it is that we have, an outbreak within a single facility wouldn't necessarily mean that everything pulls back. We would have to do aggressive, contact and try and limit that spread by all the strategies we have at hand, and those are outlined and the facilities are aware of those. On the other hand, if we're seeing increased community transmission, we're seeing an increase, we're going to be looking at multiple fronts, I guess is what I'm saying, and monitoring multiple fronts. If an outbreak in a skilled nursing facility is in the context of other issues that we have concerns about, that may be a pulling back point. But as we've seen in other places, you can have an outbreak in a skilled nursing facility in the midst of a community that's actually doing pretty well. But you just happen to have somebody introduced into that setting. So.
Well, I think we're a little bit low on time, and so I want to apologize to viewers out there. I'm not sure which camera you're at, but if I didn't ask something that you wanted asked, then I'd encourage you that both Sheriff Honsal and Dr. Frankovich have been very good about taking questions from the media. So if something else occurs to you, contact your favorite media outlet and get them to ask it for you, and I'm sure we will. But I wanted to give Dr. Frankovich time to sort of close with her thoughts about this discussion and what anything I didn't ask and what we might look at going forward.
Yeah, well, I think it was great that we've been able to walk through the framework and talk about where we are and all those things, and because I really do think it's a really good outline of where we need to be. And I also, talking a little bit about what some of those first steps out might look like, and how we would execute those. I think, again, the buy-in in terms of getting input, that having, businesses and schools and everyone else really into that planning process with us is really important. Because, again, I think we're all eager to move forward, and the more ready we are for that moment that we are able to do that, the better off we will be. And it doesn't mean everyone will move at the same time, but it will mean that, we'll see what that first grouping looks like, and we'll be prepared then for the next grouping as well. So, this has been a community-wide endeavor. There is no question about it. And we could not have been as successful as we have been at giving us this time and slowing transmission had everyone not been doing what they could to help. So, I want to thank our general community members as well as, the Board of Supervisors and our city and, township officials as well, the, public health, DHHS, all of our partner agencies from law enforcement through first responders, our hospitals. Everybody has really made this collective effort, and as a relative newcomer to Humboldt County, I must say it's been amazing how people are willing to form partnerships and work together. And I find that's often the advantage in small, in more rural areas. We may not have as many people, but we know how to bring people together and make things work. And I think that's a huge advantage for us. So again, we've come a really long way in a really short time, as you mentioned at the beginning. And I know it's been a ton of change for everybody involved, and that's incredibly challenging. But I also feel like right now we're going to embark on yet another period of change, and it'll be hard in some ways. But I also feel like it's a really hopeful time. I think people had feared that we would sit exactly as we are for as far as they could see, and didn't really feel like there was a light at the end of the tunnel. And what I want to say to people is, we're really coming close to that time that we're going to be able to start moving on this. We really recognize the need for that. And, we know there are consequences no matter which way we go. And what we want to do is do the best job we can in sort of keeping the community safe and healthy as much as possible, knowing there's going to be a little trade-off there. People are going to get sick. But really trying to balance that against what we know has to happen in the community for us all to come through recovery. So, going forward, I guess I would just ask that people realize that, it's going to be a cooperative effort. We're really going to have to pull as one in this to make it work. And when we are, hopefully we'll just forward slowly through. If we have to pull back, we'll do that as a community as well to make this work and to keep us all healthy. So I just appreciate the efforts.
Great. Well, thank you so much for answering questions tonight.
Yeah. Thank you.
Thank you, Dr. Ennis.
Appreciate it.
Thank you very much. So thank you all again for tuning into tonight's discussion. Our COVID information line will be accepting phone call questions tonight until 8 p.m. and then opening up again tomorrow for our regular business hours, 8 a.m. to 7 p.m. on weekdays and 10 a.m. to 5 p.m. on Saturdays. That phone number again is 707-441-5000. You can also email covidinfo@co.humboldt.ca.us. For the most accurate local information regarding COVID-19, we encourage you to monitor our website, humboldtgov.org, or follow us on Twitter, Facebook, or Instagram at HumCoCovid19. Thank you again for joining us. Stay safe. Good night.